request Dr. ANAND PARTHASARATHY for his talk on Visco dissection for type 2 bubble.
As my slides come up, Arundhati, can I apply? So I was just also curious whether you looked at any interface when you put an OCT over long term, because in SMILE very occasionally, even just with lenticule removal, there is some interface haze which takes about 3-4 months to really settle down.
When we did our initial series of Hulk cases, where we did not want to go all the way down to the Descemet's membrane, we did notice that there is a lot more haze. And when we followed them up over a year, 2 years, and 3 years, the haze actually continues to settle down over time because of stromal remodeling and keratocyte remodeling. So it does reduce, yeah.
And ever tried combining it with like a limbal stem cell transplant? Is you doing such a lot of extensive dissection, limbal stem cell deficiency? No.
No.
My videos have also been translated.
We would have a group photograph at the end of the session, and we would request our audience to ask all the questions at the end of the session. Meanwhile, is there any questions from the audience? Till Sir is setting up the system. So he's on. Over to you, sir.
All right. Thank you. And it's a pleasure to be among friends again. I'll just stick directly to the point about why type 2 bubbles are important. Type 2 bubbles occur in about 10% of the total big bubble valves. And the type 1 bubble, I'm sure there are some among us who get 80-90%, but the range is about 40 to 80%, depending on the surgeon, technique of injection of the air, the amount of dissection that you do. And if you have a type 2 bubble, there are higher chance of conversion to PK. Now there are some predisposing factors for which the type 1 bubble you will not get, you will probably get a type 2 bubble. One is superficial air emphysema, and that's one reason we described way back in 2004 when I was with Anshu and SNEC to actually do a superficial lamellar keratectomy before you actually inject. The advantage is that the chance of getting the type 1 bubble is a lot more, especially in keratoconic patients. If you have a patient with macular stromal dystrophy or any corneal scar, you can get a type 2 bubble because the dissection in the central part that doesn't seem to be very good. The air escapes to the periphery, and then the bubble then starts from the periphery. Very occasionally in advanced keratoconus, when you try and inject a bubble, you end up with a type 2 bubble as well. Now this is a partial type 2 bubble, and as you inject, you could make out that it starts from the periphery, and it is predominantly in the deeper, in the deeper layers, and you would very rarely sometimes get in stromal dystrophies a complete bubble. Now what that happens is then it changes your surgical plan. And in this patient you can see very carefully that you got a peripheral bubble in one edge of it. This video I got where they had an initial injection itself, you had a complete type 2 bubble. Now this really does change your surgical plan because you can no longer do what you planned for, which was a type 1 bubble in keratoconus. In this, you would definitely have to do a manual dissection, which would be the safest. In the video that they showed, they actually did an incision, they injected Visco, and then went ahead with the dissection with scissors. Now, you need to, I'm sure you know that the thin Descemet's is actually very, very prone to perforation, even with the touch of the scissors, which does not happen with the type 1 when you get it. And in this series, as they completed the dissection, they exposed the Descemet's, they were just washing the Visco, and sometimes you can get rupture just with that saline. So you've got to be very careful in these kind of very thin Descemet's where you can get perforation with just flow of the fluid, and you end up converting this into a peaking. Now, intraoperatively, of course, you can differentiate a type 1 from a type 2 quite easily. You have the anterior surface of the Duval's layers. When you create the type 1 bubble, you have a rough looking surface, few stromal fibers. And in the type 2, you will have a very, very clear descemetes. The surface is featureless, no visible fibers. This type of bubble is more susceptible to rupture, as we can see, because it's no longer protected by the extra 15-20 microns of the collagen layer of the Duval's. There is one small report by Pratik on where he actually did serial OCT. So he got a partial type 2 bubble, he did the dissection, and then he followed it up serially, and the type 2 bubble actually spontaneously reabsorbed. So in a lot of patients, if you get with a type 2 bubble, it's a good idea to go ahead with your manual dissection, and we can get to that pre-descemetic layer, and I'll show you something that I use quite commonly. You can get very, very good results. The option of releasing the type 2 bubble is something you need to take on table. Some people leave it, some people release it, but that's an option you can look at. Now, there's one article which I found interesting was from this group where they looked at the various methods of management of the type 2 bubble. And in these 31 odd patients, they found that when you have basically a type 2 bubble, if you try and do a DM bearing, the chance of conversion to PK is a lot higher. But if you do a combination of manual and a bit of Visco, you can get away with a DALC. Now, what is this visco-assisted dissection? Is you do a superficial keratectomy, which I really do prefer. It helps you go deeper. And if you got in this, you can make out a peripheral type 2 bubble. You go if you have an OCT, which some of us do have, it makes life a lot easier. But if you're looking predominantly at the way the fibers separate, you go deeper and deeper, inject a bit of Visco into the deeper layers. What that does is it separates the deeper layers. You can go ahead with either a iris repositor or a lamellar dissector, and you make sure that you are aiming to get to the pre-descemetic layer. Of course, you need to avoid using sharp instruments in this point, and you need only about 5 to 6 millimeters of pre-descemetic removal over the pupil to actually get good results. You inject Visco, the Visco pushes the pre-descemetic and the descemes Duval's layer down. You can do it multiple times. You can inject multiple times of Visco injection in the deeper layers. They usually does separate quite easily. Do a peripheral dissection so the plane across the whole bed is actually quite uniform. Once you do that, you can actually come to the center, go deeper. In this, we did try to remove the central part as much as possible. If you do not do a peripheral dissection, they tend to have very irregular healing, and some of them do end up with a fair amount of irregular astigmatism. You find one area where you have a bit of a type 1 bubble, that is a deeper bubble. You inject the Visco through that, and with the Visco layer, you use basically a broad iris repositor and use a blunt scissors. You can expose the pre-descemetic layer without actually touching. This works quite well. You can get a very clear bed at the end of the procedure, even if you do not bare the descemes. The manual dissection, something of what Rishi describes quite well, is starting from the periphery and then coming into the center, is something that can be done quite well. You just use a blunt dissector, go across, have multiple dissection of the stroma done. What that does is that you have a uniform plane. In these patients, even if you get about 70-80 microns leftover stroma, most of them do well with 6/12 kind of vision with a pair of glasses. Always do the peripheral dissection before you come to the center if you're doing a manual dissection. The option to use viscoelastic in this is probably less because you do not plan to go down deep. The deeper you go, a better idea would be to use viscoelastic. If you're going more superficial, a dry dissection with a bit of saline usually works quite well. So in summary, deep stromal dissection or expanding the type 1 bubble with cohesive viscoelastic would be the good option. A manual dissection up to the pre-descemetics give good surgical outcomes. DM bearing techniques should be avoided in the type 2 bubbles if you're not very confident of completing the dissection. And of course, avoid high volume irrigation for type 2 bubbles directly on the stroma. Thank you so much for your attention.
Thank you very much, Dr. Anand.
Should we comment or conclude the session? So the only comment I have is that I like to use viscoelastic to dissect the descemet membrane. If it goes into the pre-descemetic space, it's fine, but when it goes into the stroma, So it actually infiltrates the stroma and make your life a little bit harder rather than easier, because you get the bulk of the stroma. So I believe intraoperative OCT might be very useful in these cases when you have to be sure where you're going. Otherwise, you infiltrate the stroma and then it becomes thicker.
The air emphysema, Dr. Malyugin, what gives you is you've got the video where I showed where you got to use a side port or a 15-degree to actually incise that layer, which is before the predesmatic, inject the visco through that, and then it kind of opens up the deeper layers.
Exactly.